What you guys don't see is JT imitating a chicken.
Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble.
Welcome, everybody. This is 1 p.m.
Shout out to our listeners in Germany, specifically the region of Land, Berlin, and Saxony. Thank you very much for tuning in. We love you.
Today, we have a special guest with us. It's Sanchita, who is a fellow medical student joining us for the episode. Hello, Sanchita.
Hi.
Hi. Welcome. You're a long-time listener, and now you're joining us on the second episode of 2023. Our presenter today is Anna, who is a doctor with critical care experience. The topic she is presenting on is respiratory failure. Take it away, Anna.
Thanks, JT. I met JT the other week and he asked me if I wanted to present something for this podcast, and I thought respiratory failure is something that came up a lot in crit care, so hopefully this can be a good episode. Firstly, I think we should just start off with the absolute basics and ask, what do the lungs do? If you had to list two main functions of the lungs, what do they do?
It's just like the question of the spleen. No one knows what the spleen does.
No one knows what the spleen
No one knows what the lung does.
Lungs, right? Anyway, thank you for introducing me.
All right, Jason, hi.
My name's Jason. I'm also
You're a long-time guest.
A long-time guest. No, the lungs, they make the oxygen go from the air into your blood.
Yep, that's one of them.
Pretty much it.
Gas
Read my
exchange,
mind.
no?
Gas exchange, yeah.
Yeah, what other gas do they exchange?
Oh, carbon dioxide, the waste product.
Yeah, exactly. So you can think of respiratory failure as a failure of one of those two things. Either the oxygen isn't really going in very well or the carbon dioxide isn't really going out very well. And do you guys know the types of respiratory failure?
So we've got two types.
Yeah.
Type 1 and type 2. Yep. So type 1.
Keep going.
So that's
You're on
more
a roll.
like the hypoxic respiratory failure with low PO2. And then type 2 has high carbon dioxide and a low PO2.
Almost. Type 2 respiratory failure doesn't necessarily have to have low PO2,
Okay.
but sometimes does. It's like a may or may not have it.
Is that more
Sure.
than 50 or less than 50?
I haven't analysed the exact
okay.
exact
All right.
stats.
That's fine. As you'll find out, JT asks
Yeah.
really annoying questions.
No, all the important
which
questions.
should
from
provide no
JT.
value, but it pops into his mind.
Yeah, so that was a perfect definition. They've actually made up two other types of respiratory failure since when I was brushing up on this topic. There's type 3 respiratory failure, which is peri-op respiratory failure, when you've given someone heaps of sedatives and they're just not breathing. And type 4 respiratory failure, which is shock related. But we're not going to talk about those because in med school terms, no one's going to ask you about those. I didn't even know about them until last week. So
My sole purpose is to pass exams, not to be a good doctor.
Stick to the first principles. That's fine.
exactly right. So JT told me I had to pick 3 first principles to basically summarize this topic for you. And the ones that I've picked are type 1 respiratory failure is an oxygenation issue, so you need to give them more oxygen. Type 2 respiratory failure is a ventilation issue. You have to make them breathe more. Either they can't breathe or they won't breathe or some other thing with the actual, usually mechanics of them breathing, but not necessarily. And then third is you can't really assess their oxygenation without an ABG. Don't feel afraid to do an ABG in these patients where they've got respiratory failure because pulse oximetry has its limitations. So let's just talk about ABGs first.
Yes, I know that they're painful, right? Because you have to stab them in their wrist
Yeah.
for it. Yeah, you do that. What's that weird test where you grab their wrists and you test their ulna or
Allen's test?
Allen's test? Yeah. See, I know what I'm talking about. Jeez, JT. No.
Oh, yeah, technically you're meant to do that before an ABG, but no one does. You just kind of wing it.
Aaron,
No, it's because you're going into their radial artery, so you want to make sure that if you mess it up and block off their radial artery, they've still got collateral supply from their ulnar artery. So then you kind of take turns blocking them off to make sure that the hand is still perfused if you block off the radial artery. If you mess up the ABG that much.
Okay.
But it's not going to happen.
I actually had a question about ABGs.
Yes.
In terms of just practice, I find that a lot of people don't use the lignocaine or the local anesthetic before doing it, but I've been recommended by a few doctors that it's the pain-free way to do it and it's more comfortable for the patient, even though it takes a bit longer.
Yeah, I think when I started, I used to use lignocaine because I wasn't very good at getting it. So lignocaine gives you the freedom of having a few stabs and it's a bit acidic, so it will sting before it goes numb. If you feel confident that you can get it, and usually people who are hypercapnic, like type 2 respiratory failure, have massive bounding pulses, you can usually get it the first time and it probably stings just as much as doing local anesthetic. But definitely when you're starting out, I recommend like even cannulas, even big cannulas, put in local anesthetic, just a little bleb, and then they won't even notice if you need a few tries.
Hide how shit you
That's
are.
Life pro tip.
Exactly.
ABGs, what do they measure exactly?
So you can get a lot of useful parameters from an ABG. That's a whole other topic that you guys should do another session on separately.
Yeah.
But there are a few relevant ones for respiratory failure. What's one that you guys can think of off the top of your heads?
PO2, PCO2,
Yep.
pH.
Yep. pH is like the obvious one. So PO2 is technically PAO2, the arterial partial pressure of oxygen.
Yeah.
That comes into the definition of type 1 and type 2 respiratory failure. And PaCO2 also comes into the definition. There's like ranges for them, but a PaO2 of 60 roughly equates to SATs of 90% in a person. So like below 60 is not great, and that's probably what I'd say is type 1 respiratory failure. But PaCO2, the normal range is about 35 to 45, so above 50 starts to become abnormal, and that's what I would attribute to type 2 respiratory failure. Type 2 respiratory failure can be that PaCO2 of greater than 50 plus or minus being hypoxic, having a PaO2 less than 60.
Less than 60 for oxygen is bad. And more than 45 for CO2 is bad.
50.
More than 50.
More than 50.
Because 45 is still at like upper limit of normal.
Yeah. Okay. So 50 and 60 are those kind of numbers. Okay. Cool.
But obviously if like someone gives you an ABG and the PaCO2 is 50.
Yeah, like borderline.
You just got to put it into the context. So pHs, when do they become relevant in this?
They become like acidic or basic. Like when the
They're
like when the blood is when it's abnormal. I don't know, like when the blood's too acidic, or I don't know.
Yeah.
It's a trick question.
So both type 1 respiratory failure and type 2 respiratory failure can make you acidic in different ways.
Okay.
Can you guys think of a way that type 1 respiratory failure can make you acidemic? The saying someone's acidemic just means their blood's acidic. You don't say people are acidic.
This might be totally wrong, but if there's decreased oxygen and there's no aerobic respiration, would anaerobic respiration kick in and increase the lactate?
Yes, that's right. So the buildup of lactic acid
Nice.
makes you acidemic.
Does that make it classify as metabolic acidosis then?
Well, if you got pure type 1 respiratory failure, then you'd end up with a little bit more of a metabolic acidosis.
Right.
But at the same time, you've got to think about the respiratory side of things. Someone with type 1 respiratory failure might be breathing like quite intensely and they'll be blowing off their CO2 and they might not even be acidic because overall they'll have a respiratory alkalosis balance out kind of. The other type 2 respiratory failure, how do they become acidemic?
CO2 retention.
And then that causes the shift to that equation. Yeah. CO2 plus H2O and then gives you the HCO3 minus and something else.
Yeah.
Yeah, a carbonic acid.
And the H plus and the H plus, yeah.
Equilibrium.
Yeah.
Bicarb and H plus.
Yeah.
Yeah, and your kidneys do a pretty good job. The carbonic acid is what makes you more acidemic with type 2 respiratory failure. Both are bad. The other thing to look at with ABGs is there's another thing that you mentioned just then.
Bicarbonate, HCO3 minus.
Okay,
yeah, that's right.
It's not chemistry. You can just say bicarb. Okay.
That's what it shows on the thing, though. It's not going to show you bicarb.
True.
Which one's more helpful?
Continue.
The bicarb can give you an indication of whether something is acute or chronic. If someone's got type 2 respiratory failure, their kidneys haven't had enough time to adjust to what's happening with the CO2, so their bicarb will only slightly increase. Whereas if someone's like an 80-year-old COPD, has 100-pack year smoking history, they have had a lot more time for their kidneys to adjust to the CO2. And you might look at their ABG and you'll find their bicarb's like really high, and it's because they've had a long time to adjust. There's kind of like rough adjustment rules that you can use, like for every 10 that the CO2 goes up, if it's an acute process, bicarb will increase by 1, and if it's a chronic process, it would have increased by 4. So like a lot more of an increase. That's how you can look at someone's ABG and you're like, ooh, yes, you've had this for a while.
So a slight increase in bicarb indicates more of an acute course, whereas a huge increase in bicarb indicates more of a chronic course.
Exactly.
Is that because of that compensation over time?
Your kidneys just have more time to like start building up the bicarb.
Yeah.
The other thing to look at on an ABG that you should always write down on an ABG is the FiO2. Do you guys know what the FiO2 is?
Fraction of inspired oxygen?
Yeah, that's right.
It is? Okay,
percentage
cool.
oxygen, yeah.
What's room air?
21%.
I guess the caveat here is if you're looking at an ABG and no one's written down the FiO2 and you see that PaO2 is 70, are you happy with that? Their SATs is 92 or whatever they are. Is that reassuring to you guys?
It depends if they're on room air or if they're receiving pure oxygen.
Yeah, exactly. You got to know what oxygen therapy they're on. And it makes a huge difference if they're on a non-rebreather, which can go up to 100% FiO2 versus being on room air.
This gives like fake results. I get that, mate.
Exactly. Yeah, you're like, 70, that's okay. That's not under my 60 that I defined earlier.
But you're like pumping them with like 6 liters of oxygen an hour. Okay, yeah.
Yeah, exactly. So always write it down. And the rough rule is for a healthy 18-year-old in my head, I multiply the FiO2 by 5, and that's what I expect the PO2 to be. And if it's way less than that, there's a pathological process going on. Things adjust for age and other conditions and stuff. But if I was on 100% oxygen, I'd expect my PaO2 to be 500. If it's way less than 500, there's something wrong with me.
Where's the 500 PA? I thought the range was like between 60 and 80 for oxygen.
If you give someone a lot of oxygen and they don't need it, you can definitely make them hyperoxic.
Okay.
Yeah.
That makes sense.
Yeah, you can have PaO2s like 300s, 400s. I don't know why these people are on so much oxygen, but it can happen.
Okay, cool.
And I think quickly before, we haven't actually gotten into the 2 types of respiratory failure. We should talk about oxygen therapy because I think I only learned about the different types of oxygen therapy when I started internship, and that's way too late probably. If you're really not concerned about someone just needs a little bit of oxygen, what's the first thing that you put on them?
2 liters nasal prongs?
Yep. Doesn't necessarily have to be 2 liter nasal prongs. Like this can give anywhere from 1 to 4 liters a minute. That's the range. Above 4 liters a minute, it's not really effective. It's just kind of going everywhere. 1 liter a minute probably is homeopathic. Do they need to even be on oxygen?
Just gives them psychological support.
Yeah. What's the next one on that list? If they're still hypoxic on, to be honest, when I get to a Met call, I just put a 15-liter non-rebreather on people if it looks like a hypoxic respiratory failure, because you can always like taper back the oxygen, but this is not the time for putting on 2-liter nasal prongs. Oh, hang on, it's not working. I'll just go up the ladder. What's the ladder again? Yeah, just like start at the highest, but just assuming that's not enough, what would you go next?
Hudson?
Yep, Hudson. And the rough range for that, because I don't expect you guys to know that, is 6 to 10 liters a minute. And then after a Hudson, what would you go next?
Is this one of those variable ones? Like
Well, no one even uses Venturis, but...
Oh, no. Okay. Non-rebreather?
Yeah, non-rebreather is 10 to 15 liters a minute, and like 15 liters a minute is like pretty close to 100% oxygen. So if you see someone with a non-rebreather on, they're like basically breathing in pure oxygen almost. And if they're still hypoxic on that, like you need to reevaluate things urgently. Have you guys heard of high flow? High flow nasal prongs?
Like turn up the volume on the on the oxygen, it's high flow. Like, isn't that?
Yeah.
Isn't that increasing from like 4 to 10 liters? Isn't that? Okay, very little from the sounds of it then.
It's like this special machine that basically blows humidified oxygen. And you can have massive flows on that. They can go 60 liters a minute. Like they just like blast oxygen into people's noses, and it's like humidified to prevent like people's noses drying out and things. Make it easier to breathe it. It's pretty effective. If someone's not able to go to ICU for whatever reason, you can keep them going on that. I'll just quickly run through the other 2. Non-invasive ventilation can be broken up into CPAP and BiPAP. CPAP is just continuous pressure. BiPAP is bi-level. So moving between 2 pressures, you're basically like putting a mask on them and making them breathe. So CPAP is like for sleep apnea. You just want to like give them pressure to like keep their airway open. Then mechanical ventilation is you're not succeeding with anything non-invasive, so you have to intubate them. You can give 100% oxygen that way, but that's the last line sort of thing.
What are iron lungs? Are those like mechanical ventilations? That's
That's like, isn't that for polio where they put them in the like,
but is that a form of assistance?
yeah,
What would it be? It's not counted.
that's like negative pressure ventilation from the outside.
Okay,
so-
never mind. No, we'll move on.
Yeah.
Okay.
Oh man, just was that
You
all
won't
were
have to do that
thinking
at
about the
Met
entire time. Yeah? These poor
really
kids with
trying to stop
tuberculosis.
himself.
Oh, no,
couldn't
polio.
control
Sorry,
it.
not tuberculosis.
Yeah, so the different types of respiratory failure.
So type 1 respiratory failure. Do you guys know some causes for hypoxic respiratory failure or like some ways of thinking about it?
You choke on your steak. It's type 1. Isn't that like a foreign body obstruction?
I mean, yeah, it
Isn't that
stops the
one of
oxygen
I
from
swear it
getting
is,
in.
right? I thought foreign body obstruction was well.
Yeah, it would be.
Anything that just
That's-
prevents you from getting enough oxygen, right?
Yeah.
Yeah, it would be choking on steak,
I'll
but
say the more realistic
Like-
ones. Happy?
Sanchita,
my
you had
God.
some?
I don't know. Is it in terms of like VQ mismatches?
yeah, a lot of the causes can be thought of as VQ mismatches. So do you guys know what VQ mismatch is?
V is for,
Ventilation,
Q is for.
perfusion.
Flow, blood flow, perfusion, I guess.
Yep, that's right. And then
Not Queen or something, in case JT was.
yeah, after that polio one, I don't expect anything less from JT. So basically, a segment of your lung, for it to work properly, the ventilation's got to happen, but also the blood flow's got to get to the lung to do the gas exchange. So if they're not matching up properly, it won't work. So you can either have the perfusion not being very good or the ventilation not being good. And do you guys know what shunt or dead space is?
Shunt is where there's inadequate ventilation and the perfusion's intact. So the V will be low. So like the equation will be closer to 0.
That's right. So what kind of processes cause a shunt?
Like just acute respiratory distress. Could that cause inadequate ventilation?
I guess that's like more of a symptom rather than an actual
right.
pathology.
Would a PE cause?
That's more dead space. The
Oh, that's not-
perfusion isn't happening, but the ventilation's perfect.
Yes.
Congestive cardiac failure?
Yeah, that would be like fluid overload, pulmonary edema. So
what would be the most common one?
Are we talking about like constriction of the bronchioles that causes insufficient ventilation?
let's just go back.
Yeah.
Shunt refers to there's inadequate ventilation, but the perfusion's fine. And dead space refers to the ventilation is fine, but the perfusion is absent. So like a big PE or something.
For shunt pneumonia.
So yeah, pneumonia,
Yeah.
atelectasis, pulmonary edema would all be shunt.
But that would be temporary then.
Yeah.
Yeah.
So asthma starts off being a type 1 respiratory failure. It's one of those weird ones where like initially they're breathing really quickly and they get really tired and their breathing slows down, and then you get like the silent asthmatic. They're not really moving air very much and they become a type 2 respiratory failure. That's really severe asthma. So asthma is one of those tricky ones that swaps from one side to the other.
And then the other one, other than shunt, the other one was
Dead space.
dead space. And that was like PE stuff because the blood can't get to the alveoli to
Yeah.
exchange, gas exchange.
Exactly.
Yeah.
What would be other causes of dead space?
A thing that comes to mind when we think of dead space is like COPD has a lot of dead space because they've got like emphysematous lungs, or like the alveoli are really like huge, and even though they have blood supply, it's kind of like stretched over the massive emphysematous lung that they have. So they have a lot of dead space. The point of all of the type 1 respiratory failure stuff is the ventilation isn't happening or they're not getting enough oxygen into the lungs. So you need to give them oxygen. That's usually the answer.
Nice and simple. Okay.
Yeah. So the way you can give them oxygen, and thinking of those oxygen therapies, nasal prongs, Hudson mask, high flow, NIV, mechanical ventilation, like they're all great ways to get oxygen in. But not all those won't work for type 2 respiratory failure. So yeah, that's the first goal when you get to a med call. Is this type 1 or type 2?
So if you were to summarize, what would be the main causes of type 1 respiratory failure? Like I would say in an OSCE or something.
I'd think about it as like usually a VQ mismatch. Like there's perfusion but no ventilation. That's like pneumonia, atelectasis, pulmonary edema, pulmonary fibrosis. And then there's dead space, which is not enough perfusion. So like big PE, but okay ventilation.
Right.
Cool. Yeah, that makes sense.
Yeah. And usually the answer is to give oxygen. But for all of these things, if there's an underlying cause, obviously for the PE one, you're going to want to treat the PE. So that should be part of your answer as well. I would give oxygen and then I would treat the underlying cause if there is one. If there's a big pneumonia, I'm going to give antibiotics. If there's a pleural effusion causing the type 1 respiratory failure, I'm going to put a chest drain in if it's 2 liters or something like that. Like, because Yeah, or give diuretics, or like pulmonary edema to give diuretics. There's all specific therapies of all of the type 1 respiratory failures that you can target.
When approaching patient, trying to determine whether it's type 1 or type 2, is that when like the first thing you do is an ABG to determine that?
The answer that you're supposed to give is you do like an A to E assessment of the patient.
Yeah, I love
and
that.
then,
No, of course.
A to
Yeah.
E,
After
history
that.
exam.
there's their airway patient, and then go on to B and
Yeah.
look at their respirate and their SATs. And then at B, because that's
Yeah.
part of your B, you'd
Do an
think about doing the AB, getting someone else to
Right.
do the ABG while you carry on with your assessment.
Getting someone
Yeah.
else. I like that.
Yeah. You would probably wouldn't.
Every
That makes
step.
sense. Yeah.
Yeah, you probably wouldn't pause at the B to
Yeah.
like get the ABG and take like 20 minutes to do that when you haven't even
You've got to
assessed
confirm
C.
goals of care, goals of care first, and patient ID before you even walk into the room. Right? Were they on any precautions? Hey, did they have COVID?
For active ward-based care.
Yeah, you forgot to
Do they have
mention hand
TB? Yeah,
hygiene,
what? Oh.
obviously.
Yeah, correct PPE. Oh.
Check if they're
It's onto me.
MRSA.
Yeah. Have you had your checks done? Have you? Are you up to date on your vaccines? No. Okay.
So that was type
Anyway.
1.
type 1. Now type 2.
Yeah, it's type 1. But actually, quickly before we move on to type 2, I did think of a like easy way to think about type 1.
Is it a mnemonic?
We like that.
No,
Oh.
just like simplifying it.
Yeah, I
So
like it.
not enough oxygen reaching the lungs. So for some reason, the oxygen is not able to cross the lungs. So that's a shunt. Or the oxygen is not able to get into the bloodstream. So that's like your right to left shunt or dead space. Like think about the path that the oxygen has to take. There's got to be some oxygen. Then it's going to get to the lungs and cross the lungs into the bloodstream. So if you think about it like the steps that the oxygen has to go on its journey into the bloodstream, and you can think about pathologies that affect all of them.
And something's screwed up in that process.
Yeah.
Yeah. Okay.
Each step of the way. So
Yeah.
what Jason was saying about choking on steak would be like the oxygen can't get to the lungs.
That'd be
that part
poor
of
ventilation. Yeah?
Yeah.
So that'd be technically a shunt.
Shunt.
Yes.
Because the
Shunt.
ventilation's too low.
Yeah, because
Yeah.
you can't get past the steak.
Yeah.
Yeah, I guess so.
Yeah.
We've worked it through.
And then type 2 respiratory failure. Can you guys you guys would know some causes of type 2 off the top of your head?
I don't know how they frame it, but central nervous system causes that depress the drive. Like it could be drugs, stroke, lesions, some motor neuron stuff.
Yep. That's basically like you can't breathe or you won't breathe.
Yeah,
So sometimes it comes from your head, like you said. So drugs, really common after an operation for people would be drowsy or like a few too many tapentidols. And then they get type 2 respiratory failure and you have to give them naloxone. As you mentioned a few other things in there that I would term something else. So like neuromuscular diseases would probably be like a chest wall reason. They physically don't have the muscles for breathing.
Myasthenia gravis.
Yeah, that's one of them. And Guillain-Barré.
So it causes the like diaphragm weakness or chest wall muscle weakness.
Exactly.
Then they can't expel CO2.
Nice.
It leads to build-up, is that?
Because CO2 is actually really low maintenance. You just need to breathe for it to go out. Like,
It's not that difficult.
yeah,
Breathe.
exactly. So if a lot of fancy things have to happen for oxygen to get into your bloodstream, but CO2 is just like if your lungs expand and then deflate.
So when you say
it'll
breathe,
go
are you
out.
like particularly like exhaling? Like that's really important because you've got the build-up of CO2.
Yeah,
I know breathing because breathing requires inspiring and expiring. But isn't it mainly like the expiration which is like messed up for type 2?
yeah, I guess so. If you think about asthma and COPD, like your obstructive lung diseases, they have an issue with expiring. Those are two other examples of type 2 respiratory failure pathologies, severe asthma and COPD.
So COPD and asthma, can they span both type 1 and type 2?
Usually for COPD, it's more of a type 2.
Type 2.
Yeah. An asthmatic's lungs can be relatively normal looking, whereas like you get a lot of hyperinflation and with a COPD. Obviously, you can get hyperinflation with severe asthmatics, but what are other things that you can think of that might cause like issues getting carbon dioxide out?
Be OSA?
Yeah, I guess if there's something called obesity hyperventilation syndrome where obese people just somehow have less the drive to breathe. So that can be a cause of type 2 respiratory failure. And then like really bad like chest wall deformities like kyphosis or like pectus.
Excavatum.
I always get them confused
Right,
about
well, it's in that Anki
perinatum.
somewhere,
and-
JT.
It's the excavatum, right? Because it's depressing in, like you've excavated a hole into your chest.
Yeah.
Whereas the carinatum is when you're like a chicken. So imagine you're a chicken and then it's pointing outwards.
What you guys don't see is JT imitating a chicken.
So excavatum would be the
Yeah. Well, I'm not sure which one, but like chest wall
One of them.
deformities.
yeah, okay.
So what you need to do for these people, putting nasal prongs is not going to fix them. You need to like make it easier for them to breathe.
You really hate the nasal prongs here.
That's my fault.
Hey, they have their purposes, but
Have you got your signed off?
maybe
Nasal
not for
prongs?
respiratory failure.
So need to.
Get them signed off today.
What do you guys think is the answer for type 2 respiratory failure? If you saw someone with severe COPD and you got their blood gas and it was 75, their CO2,
How do you force someone to breathe?
that's a good question.
Yeah.
Was it the BiPAP machine?
Yeah, most hospitals you have to go to ICU for that. They won't do it on the wards. There's some like initial thing that you can do before you get to the BiPAP.
Breathe harder.
Come on, man.
push that in.
So the respiratory drives comes from the carbon dioxide, right?
Yeah, but these people, like, they're just not breathing. So what are you going to do to them, JT?
Yeah, get a motivational
Oh.
interview then.
Can you intubate them?
So you're not going to give them BiPAP, but you're going to intubate them on the ward.
I'm stuck, Sanchita. Help me out.
It's a bit tricky. You can
You, like,
actually just
jump on their chests and then like, try to like give them, like the physios do. They do these, what you call it, like
chest physio.
yeah, chest physio. You get them to like, I don't know.
This is
Yeah. Are you going to volunteer to do
No.
that for the whole night?
The paper bag ventilation, is that?
That's for like
Oh.
anxiety, right?
So that's for like hyperventilation and like respiratory alkalosis. You get them to re-breathe their carbon dioxide.
You don't have enough
You're making it worse.
CO2. You're blowing off too much CO2. You need more
Yeah,
CO2.
you have too much CO2. Keep
Yeah.
breathing it in.
That's like the opposite of giving them oxygen. You're
That's what I-
depriving.
So you can give them high flow because there's two things on high flow. There's either FiO2 and there's also flow rate. So you can just keep the FiO2 rate like relatively low, but you want to give them lots of flow. And what that does is gets rid of like all the dead space they have in their mouth.
So you're just flushing them out with
You're-
air.
Yeah, there's a lot of carbon dioxide sitting in their
Okay.
Oh
mouth.
my god, is this like denitrogenation in what they do in anesthetics? Is that the same principle?
Denitrogenation.
I feel like you made that up.
No, no, no. At least the
Yeah, like
anesthetic
washing out
consultant was
the-
when you
yeah.
before they do the anesthetics, they put the 100% oxygen on for like 3 to 5 minutes to push
Oh, you
out
mean
all the
like
nitrogen.
pre-oxygenating someone?
Yeah.
Yeah. Oh, this is like there's a lot of dead space in your mouth, like anatomical dead space, and it's basically like moving the carbon
Displacing the
dioxide
carbon
out, and
dioxide.
also theoretically provides some PEEP, and it makes their breathing a little bit easier. With-
So you'd say I'd put them on high flow oxygen through a, like, what mask would you choose?
High flow is just humidified nasal prongs,
Okay.
and basically you just like turn the flow rate up as high as they can handle, which is
Nice.
like I don't know 60 liters a minute, something crazy. They've got like air blasting in their face, but sometimes if it's like only mild, it's like enough to tide them over and makes their respiratory effort go down, and
Oh,
they can maybe avoid BiPAP. But usually, if it's like pretty
Yeah.
bad, they need BiPAP
I
anyway.
think I've seen that on the wards, and yeah, it's very loud, right? The high flow.
Yeah, like patients hate it because they can't hear themselves.
Yeah, it's super, super loud. I remember.
And you keep the FiO2 low or keep it at 20% or even lower.
Well, sometimes these people don't even need oxygen because their PO2, as we talked about, can
Oh.
be either like normal.
So just
or
actual
low.
air, just
You're flushing them.
oh wow.
Yeah.
Okay.
Flush that CO2 out.
Wow.
Like usually you put 30% or something if they don't really need oxygen.
Yeah.
I see.
But
yeah.
reduces their respiratory effort through PEEP, positive end expiratory pressure, because you're just like blasting air in their face. And then the dead space washout of the CO2. We actually use it quite a lot for like COPD patients. But the answer to all of these respiratory failure management pathways is you just got to treat the underlying cause as well. So if you think about COPD, you got to get on top of their inhalers. You got to, like, if they need antibiotics, you give that to them. They need steroids, give that to them. With the neuromuscular disease, like, I don't know what these steroids and immunoglobulin, and like you might need to intubate them for a while until they recover. You just got to like think about the underlying cause all the time when you talk, because respiratory failure is kind of like a consequence of something else going on. Like something happened to them and now they can't breathe very well. Always think about that. I guess we can like touch on investigations. We talked about ABGs. You're going to do OBS. You're probably going to get an ECG. micro if it's relevant, like they got a pneumonia, send off a sputum, or if they got fever, blood cultures, other investigations. It just all depends on the underlying cause.
Yeah. It's like the welcome to the hospital chest x-ray.
Welcome to the hospital. Yeah, so you probably do a chest x-ray as part of this, but there's one caveat. If you think they've got a PE,
Oh, wow. Okay.
are you going to do a chest x-ray that's probably going to look normal? Or should you just do a CTPA?
Yeah. CTPA.
Also,
Yeah.
in terms of just recognizing the patient in respiratory failure, like could they present unconscious? Could they present just with signs of respiratory distress? Or is it quite obvious that this will be a respiratory failure station?
So I think for type 1, it's pretty obvious. Like if someone's got a raging pneumonia, you can tell because they're like breathing really hard, their rest rate's like 30, 40, they're struggling for air, they've got all the like accessory muscles being activated, their SATs will be low, and they're maybe confused and things like that. Whereas like I've had a few type 2 respiratory failures present really vaguely. I just happened to do an ABG on him because his SATs were normal, but he was a bit like tired and confused.
So type 2, they're like just a bit kind of drowsy and non-specific. And then type 1, they're like, they look acutely unwell and they look like they're about to die almost. Or
Exactly. And the fatigue like kind of catches you off guard. Like one of the type 2 respiratory failures that I didn't really talk about was the post-op like one with like a sedatives one that giving the naloxone.
Yeah, exactly.
Yeah. So you're just like, they've just had a surgery. They're just like a little bit tired. They're just chilling. Then you do an ABG and their CO2 is like 80 and you're like, ooh, okay, they're a bit more tired than I thought. Like it just catches you off guard. Yeah, this guy ended up going to ICU and he didn't look that unwell, to be honest. His wife was just like, he looks a bit tired. So yeah, just being aware of the really vague presentation. Like they do look a bit more tired. They might have a bit of a headache. They might be a bit flushed.
Would you want to, in terms of the assessment, you do B and give them a mask and then later on, after doing the rest, then reverse the opioid with the naloxone? Would the treatment of the underlying cause happen after you've given them oxygen therapy? Like, is that the priority?
Yeah, well, it takes a little while for nurses to go to the med room, get the naloxone, draw it up, etc. But just for like, if you guys are interested, this comes up a lot because there's a lot of post-ops that you have to see. Naloxone is very fast acting, but it also wears off very quickly. So like you get one ampule and you dilute it up into 10 mils and basically like if you give it to them, they'll basically perk up straight away and you'll be like, this is amazing. And then you walk off. And then they'll go back to sleep again and they'll go back to type 2 respiratory failure. So you basically like sometimes need to do a naloxone infusion because it's got such a short half-life. The nurses will be like, oh my gosh, she's unconscious again. And you'll have to keep coming back. But you should put oxygen on because that's the easiest thing. You have it right there and then like treat the underlying cause and like withhold all the future opioids and stuff like that. But never give a whole ampule of naloxone in one go because like imagine someone's had a hip replacement and they're in terrible pain. Maybe we overdid it. We gave them a bit too much oxy and then they're in type 2 respiratory failure. You give them the whole ampule, you reverse everything. Yeah. And they'll just scream and they'll hate you. And it's really dangerous.
No pain
Much to
relief,
balance.
Yeah, in summary, type 1 respiratory failure is an oxygenation issue. There's some issue with the oxygen getting into the bloodstream and then to the tissues. So from a lung perspective, you can usually think about it like a shunt or dead space. Examples include atelectasis, pneumonia, pleural effusion, pulmonary edema, big PE. And the solution is usually give oxygen and treat the underlying cause, whatever you decide the underlying cause is. And probably as part of respiratory failure workup, you've got to do an ABG and a chest x-ray, like compulsory investigations. But if you think it's a PE, CTPA. And then for type 2 respiratory failure, it's an issue with ventilation. They might also be hypoxic as well. Examples include anything that prevents the CO2 from leaving the body. So like COPD, really severe asthma, CNS depression, neuromuscular diseases, chest wall deformities. And the way of treating that is by allowing them to breathe more. That might involve non-invasive ventilation like BiPAP, intubating them and literally breathing for them, or like you can sometimes get away with a bit of high flow just to reduce their work of breathing, like in COPD, and then they do it themselves. Then how would you manage type 2 respiratory failure is like apply those therapies and treat the underlying cause, whatever you decide that is. So if it's a like opioid or overdose, give them naloxone, for example, because a lot of these have underlying causes. So as long as you remember that and do an ABG.
So that's a buzzword I got to say in my OSCE as well. Treat the underlying cause.
That's actually true for like everything that you'll get in your OSCE.
Yeah.
Thank you so much, Anna. Thank you for all your time today. And thanks to all our listeners out there. Feel free to check all our notes at 1pm.wiki. And if you'd like to join the podcast, feel free to contact any one of us.
Thank you.
Thanks.
Thank you.
Thank you so much for listening. We're really excited to be collaborating with Becky from Becky's Notes, a UK-based resource to produce an infographic for our visual learners out there. Becky's Notes bring together all the key topics medical students need to know in a readily available place, reviewed by specialists in the field. These visually striking notes are a refreshing change from all these boring textbooks out there. You can check her out on Instagram at Becky's Notes 01 and support her at the links below.